Anyway, good morning, ladies and gentlemen. Let me thank the AOS for this wonderful opportunity. I'm going to give you 7 pearls of how to manage this IFIS, which is becoming a huge problem. So what is the biggest problem in phaco? Is it hard brown cataract, PPC, subluxated, or a pseudo exfoliation? Unfortunately, no. Okay? The biggest problem is the small pupil. Why the small pupil? Because in small pupil, you are not able to see anything, and that is the reason why all the complications can occur because of the small pupil. Now, what happens is alpha-1 blockers are used for benign prostatic hypertrophy. These can, even short-term use can lead to non-reversible iris dilatation function in many patients. And tamsulosin is a commonly used progressive intraoperative wherein the pupil starts coming down on you during surgery and making your life very, very difficult. Iris prolapse, billowing of the iris, the incidence is as high as between 33 and 78%. And as I told you, tamsulosin is a alpha blocker. It relaxes the smooth muscle of the bladder next, so the patient is able to pass the urine much better. And the iris dilator muscle, it works on the iris dilator muscle as well, renders ineffective dilatation drops. And there are also some antihypertensives which can also cause this IFIS, and that's the reason why you see it in not uncommon in women as well. And some of the women also take this alpha ones or the Urimax for many reasons, for urinary incontinence or something like that. So this iris prolapse is very, very typical of this. I can see once you do the hydro, the iris starts coming out of the port, and if you try to push the iris back, it becomes seeing, and the iris will tear. You can see there's another patient with the IFIS, wherein the iris is coming out through all the ports, okay, both the side ports, main port as well, making your life very, very difficult, because every time you push the iris becomes small, or the iris will tear. You can produce hydrodialysis. This iris dance, okay, very, very typical of this. This thing is called billowing of the iris, which is very typical of patients on Urimax as well. What are the complications? Iris chafing, you can name the complications, it's all because of small pupil. Iris bleeding, prolapse, hydrodialysis, zonal dialysis, PCR, nucleus drop, difficulty in IOL implantation, prolonged surgical time, and it's going to make, as you can see here, another patient, you can see I'm doing a bimanual phaco long time back. Even before David Chang described this, we didn't know what exactly the problem is. As you can see, there is the iris chafing as well. And the iris starts coming into the port and making your life very, very, again, a PCR and a nucleus drop. So what is the number one protocol? Past or present use of alpha blockers. Go into the history. Many patients don't, many physicians also don't understand. Many ophthalmologists may not understand this thing. So patients, unless you tell them, are you using any drug for passing urine? Okay, prostate means they will not understand, and you need to tell them. And stopping tamsulosin will not help. Atropine some people are using, that also doesn't help. Less than 6 millimeter dilatation is a red alarm for you, because irrespective of density or cataract, this is going to become 2 millimeter or 3 millimeter during the surgery. So I would straight away go in for an iris expansion device, either an iris hook or a Maligan, which we're going to talk about. You can use intracameral phenocaine plus, intracameral epinephrine. All these combinations are available, which is there. Many companies, Entod is making this phenocaine plus, the Sunways is making the T plus, which is a preservative-free, a combination of tropicamide, phenylephrine, and propracaine as well. Again, well-constructed corneal incision. What I do is I try to do the catalyst or the femtocataract for these patients, because I'm able to get a truly triplanar incision. But if you're going to do a manual incision, go for an anterior incision, longer incision, low threshold to suture. Calibrated side port incisions are described by Rohit and Tushya Om Prakash of Amritsar. You can see here the incision which I made with this thing is a very typically, if it's going to be too long, it's going to make your life difficult. If it's going to be too short, definitely you are adding fuel to the flame in a patient with the IFIS, because that's going to come up. So you can see here again the manual incisions. What I'm considering is constructed corneal incision, both main port and side port. Don't take the side port for granted, because the side port also needs to be a little longer incision and self-seating as well. You can see how long I'm going into the, starting a little anterior. Then normally I start a little posterior in the posterior limbus or the limbal vascular arcade. Here I start a little anterior and go anterior, so making sure that the iris does not come. Again, a strict no to HPMC. Okay, in HPMC makes the pupil a little more hypotonic and IFIS can worsen. I would suggest the use going for Hyalon or even Viscoat for these patients and disperse a combination of the Viscoat and the thing or the soft shell technique described by Steve Arshinoff. You can see I'm putting Viscoat to protect the endothelium underneath. I'm putting the Hyalon. This will make sure that the iris is pushed back, and even if the, see, don't think that this pupil is well dilated and you will not be. This patient is on tamsulosin. This pupil is going to definitely come down, and making sure that in the beginning itself you do that. Don't do an aggressive hydrodissection. You have to be very careful. Again, trypan blue rexis, because even it's not a major cataract, do a trypan blue because rexis, because you know exactly where your rexis margin is. If you don't have trypan blue, you do not know. If the pupil comes down on you, for example, this pupil is about 5-6 millimeter, but if it's going to come down on you, then you know exactly where your rexis margin is. So again, you can see here, I'll quickly finish off. Even if it's a well dilated pupil, I do a trypan blue rexis. Low fluidic heights, making sure that the bottle height is 80 centimeters, the vacuum is less. Normally I use about 400-500, and the AFR is also, normally I use about 40-50, but I use only 25. So again, switch off the irrigation when you come out of the eye. This is not, you should not do in an IFIS patient. Switch off the irrigation, or switch off the irrigation when you go in or come out of the eye. Iris retractors, iris rings, I don't have to mention right in the beginning of the surgery, because halfway through the surgery, after putting the rexis or doing the rexis, the pupil comes down, very difficult to put your iris hooks or a Mulligan ring. Subincisional iris hook can also be done as described by David Chang. You can go for a Mulligan ring, as you can see here in this particular case, or you can go for a BX ring, which is also very, very easy. But more importantly, the take-home message is, an IFIS, better to be safe than sorry, because you can end up in a very serious problem, and this is a surgical strike which is likely to happen tomorrow. Thank you very much for the wonderful opportunity the patient attended.